Hi all, this is Professor Elliott. This is chapter 54, covers anemia. So anemia involves blood formation, right? The lack of blood formation, or for whatever reason, if the formed blood leaves the body. So let's talk about blood formation first. So hematopoiesis is a word to discuss the formation of new blood cells. Now, our bone marrow creates our blood cells. So it creates the precursors for our blood cells. So hematopoiesis is the formation of new blood cells. Erythropoiesis is the process of red blood cells are called erythrocytes, so the process of erythrocyte formation. Anemia then is not enough blood. So there are many reasons this can occur, but anemia is not enough blood, specifically red blood cells. So the first class of drugs we'll talk about are erythropoiesis stimulating drugs. So these are drugs we may use for anemia of chronic disease, which basically means your kidneys aren't working well, so you don't have enough red blood cells. Chemotherapy can cause harm to blood cells, and then certain treatments for HIV. Epoetin alpha is the drug in this class, and what epoetin alpha does is mimic the body's natural epoetin process, so the natural erythropoiesis process. Epoetin alpha stimulates the kidneys to make more red blood cells. And to understand what this does, to understand the action, we have to understand the process of erythropoiesis. So when you or your patient or me, when we, for whatever reason, have low white red blood cells, our kidney detects it, and it can be in small levels, but our kidney detects that we have hypoxia or low oxygen carrying capacity of our blood. Our kidney then tells our bone marrow to create more red blood cells. Our bone marrow listens. It sends epoetin out to the bone marrow, that's the signaler, and it tells the bone marrow to create more red blood cells, and the bone marrow complies. So here's the process again. Kidney senses hypoxia, it sends out epoetin to promote production of mature red blood cells in the bone marrow. More red blood cells in circulation leads to increased oxygenation and lower levels of hypoxia, reduce inducible factors suppressing EPO production. So it's this whole process. If we have enough of the red blood cells, the epoetin stops. If we don't have enough, the epoetin starts. So these drugs help to tell our bone marrow to make more red blood cells. Some adverse effects include hypertension. So uncontrolled hypertension would be a contraindication to using these drugs. Now, I don't need you to know these certain hemoglobin levels, but I just want you to know that we keep the hemoglobin level a little bit lower than normal because we don't want to have that uncontrolled hypertension as a result of this. We can give iron. Patients may experience iron deficiency anemia. So iron helps the oxygen bind to hemoglobin. You can see in this picture. A contraindication to the use of iron is if a patient has a condition called hemochromatosis. This condition is literally too much iron. The patient has too many red blood cells. We wouldn't want to add more to that. A lot of adverse effects of iron revolve around the gastrointestinal system. So iron can create nausea, it can cause stool to turn green, it can create constipation. We have some different forms of iron. A lot of times when we give iron, it's in an oral form. It may be incorporated into a multivitamin or in an iron supplement as itself. There are a few different forms, fumarate, sulfate. I don't need you to know those different forms. Iron dextran then can be given intramuscularly or intravenously for iron deficiency. And iron sucrose can be given IV for chronic kidney disease. So here are some strategies for helping your patient deal with nausea related to iron. You may tell the patient to wait 30 minutes before lying down. You may see if the patient can divide the dose and take the medication twice daily, or take it alternate days, which is better tolerated. And if it's not urgent, the patient may start by taking iron twice a week and then building up. With this, the GI effects are hopefully going to get less as time goes on. So let's answer this response question. Which instruction should the nurse include in the teaching plan for a client taking iron supplements to correct iron deficiency anemia? Should they eat a low fiber diet, limit the intake of food, limit the intake of meat, fish, and poultry, avoid taking the iron supplement with milk or antacid? Now, I'm going to tell you, most conditions you would not limit fluid. We need fluid, right? And limiting the intake of meat, fish, and poultry, that's the majority of the place we get protein. We can't limit all of them. Maybe if it's at a specific type of meat, you would think so. So try to look at this big picture. Any of them just like ridiculous answers. So I may argue that B and C could be seen as just incorrect across the board. So we want to avoid taking iron supplements with milk and dairy products. Anything that contains calcium. What happens is the calcium binds with the iron and renders the iron unusable. Now let's see what we should take iron with. So the nurse is instructing an adolescent diagnosed with iron deficiency anemia about the administration of oral iron preparations and should tell the adolescent to take the iron preparation with which best fluid to enhance absorption. So should we take it with milk? Well, we just learned that calcium and iron don't go together, so we can cross that off. Should we take it with water, apple juice, or tomato juice? So we are going to take it with tomato juice. And that is because it is recommended that iron be administered with vitamin C rich fluids. The vitamin C aids in absorption of the iron. Okay, something else. So what action should the nurse take to avoid skin staining around the injection site of intramuscular iron? Would we administer the injection into the thigh, massage the site well after injection, use a Z-track method for administration, or administer the injection in the non-dominant arm? Well, I know that any injection, I'm not going to massage after I do it. It's going to cause tissue breakdown. It's going to cause increased absorption. It's just overall not good. So I could cross B out. So avoid skin staining. So what do we know about the Z-track method? So the Z-track method actually creates a Band-Aid of the person's own skin. So you can see here, the needle is injected into the muscle while the skin is held taut. When we release the skin, it covers up that injection into the muscle. So the medication stays in the muscle and does not seep into the skin. If we do not use the Z-track method, you can see here on the right, that is an example of skin staining related to iron administration. We would obviously want to avoid that. Something else, so just across the board, think iron can be staining. Oral iron supplements can cause teeth staining. So if we're giving liquid iron, it is essential that we give it with a straw. Now, IV iron can be dangerous. IV iron infusions can result in reactions like headache, nausea, muscle pain. We can get a severe allergic reaction that could even result in anaphylaxis. And then extravasation, which is the leaking of the medication around the IV site, is rare, but it can lead to skin discoloration, as you can see here. Folic acid is the last thing we're going to talk about. So folic acid is a B vitamin. The deficiency of folic acid is often caused by malabsorption. Folic acid is absorbed in the upper duodenum, so the upper smaller intestine. Folic acid is important because it is essential for erythropoiesis, or the formation of red blood cells, and nucleic acid synthesis. So that makes this really important in pregnancy. We need to have an adequate supply of folic acid during pregnancy. This is to prevent neural tube defects such as spina bifida, where the spinal column does not close. It is recommended that women who want to become pregnant start taking folic acid like a month before to allow folic acid stores to get sufficient and to be at the best level they can. Folic acid does have an adverse effect of potentially causing yellow urine. Which laboratory studies should the nurse monitor to evaluate the effectiveness of supplemental folic acid therapy? So should we monitor blood glucose, blood urea nitrogen? Now this is a measurement of the effectiveness of the kidneys and hydration. the complete blood count, or alkaline phosphatase. So we are going to monitor a complete blood count, as this medication, folic acid, is essential in erythropoiesis, which is red blood cell formation.